I thought it would be useful to revisit dysplastic nevi. It does appear to me from comments that people post that quite a few people really do not have a proper understanding of the nature of dysplastic nevus, and there is a tendency when looking at a melanocytic lesion, if there's any atypia in it, then it seems to get lumped as a dysplastic nevus, which is really not appropriate. It's worth reminding you that cytological atypia can be found under a variety of circumstances in addition to dysplastic nevi. So you can see atypia in neonatal nevi, in recurrent nevi, in nevus of special sight, nevi of the ear, nevi of the scalp. So I think it's important that we revisit dysplastic nevus and make the definition perhaps a little clearer. Now, I thought it was quite interesting just to go back to the history of dysplastic nevus. The first description of familial melanoma was made by Dr. Norris in 1820 when he described the post-mortem findings in a patient with metastatic melanoma. He didn't actually recognize it as melanoma, but when you go back to the paper, that's obviously what it was. And it turned out the father had the same condition. Now, when I was training in Belfast, Professor Florence McKee was my mentor, and she recognized an unusual nevi which she called active nevi, and in retrospect these active nevi were in fact dysplastic nevi. And then Dr. Monroe in 1974, he described an association between active junctional nevi and melanoma. So in fact he described dysplastic nevus syndrome before Wallace-Cork introduced the concept of the BK mole syndrome. And then I think we have to lay the blame for the term dysplastic nevus on David Elder, who recommended the use of this term in 1980. And although there was a lot of argument over the next decade or so, led I think by the late Bernie Ackerman, there was a lot of argument about the use of the term dysplastic, but I never really could see the point of this argument. I was always quite happy to use the term dysplastic nevus, and that has now become the standard term. And then Marty Mim from Massachusetts General Hospital, he introduced the 3-tier grading system of mild, moderate, severe in 1985, and I'll get back to that in a little while. So what's the point of even recognizing dysplastic nevi? Well, I think there are two reasons. One is that it may, when you see a case down the microscope, it may come from a patient with dysplastic nevus syndrome, and those patients develop hundreds of lesions and are at great risk of developing melanoma. And also of importance is when you are looking at a high-grade dysplastic nevus, it's important to look very carefully to make sure there isn't melanoma arising within that nevus, which is not uncommon. So clinically, dysplastic nevi, clinically they can look awfully like melanoma, They're irregular, variably pigmented, often greater than 0.6 centimeters in diameter, and typically have an irregular border. So the clinicians are never quite sure whether they're looking at a dysplastic nevus or a melanoma, which is why, of course, they get excised. And dysplastic nevi are not uncommon in a sporadic setting, affecting somewhere between 2 and 8% of the population. Now, the UK definition of 50 or more nevi with at least 3 atypical forms is, I think that's a good definition, but the British Association of Dermatologists reckoned that 2% roughly of the population had dysplastic nevus syndrome, and I have to be honest, I don't believe that for a minute. I think from my time in Boston, dysplastic nevi are very common, and they're almost always in a sporadic setting. Patients with dysplastic nevus syndrome are far and few between. And this is a high power of a dysplastic nevus, and you can see why the clinician would be worried about whether that's a melanoma or not. Now, this is the most important slide, really, and it's really important that pathologists recognize that in addition to cytological atypia, to use the term dysplastic nevus, there must be architectural disorder of a well-defined type. Dysplastic nevi are lentiginous and nested. If they're compound, the junctional component extends beyond 3 rete ridges from the dermal component, and the junctional nests are abnormally distributed. They're not present at the tips, they're not necessarily present at the tips of the rete ridges, and are often found along the sides of the rete ridges and sometimes overlying the dermal papillae. And bridging, as you can see on the slide on the right, which is an amazing example, bridging is a feature that's commonly present. So I must stress that these architectural changes are essential before you make a diagnosis of dysplastic nevus. And I'll talk a little bit more about grading into low and high grade. Fibroplasia, again seen on the right, is a common feature of dysplastic nevus, but it may be seen in other atypical nevi, particularly nevus of special sites. So you've got to be careful you don't put too much weight on fibroplasia unless it's in the setting of an otherwise obvious dysplastic nevus. And importantly, one doesn't see any evidence of pagetoid spread, and if there is a dermal component, there are no mitotic figures. If you find mitosis in the dermal component, then the whole thing's melanoma, not dysplastic nevus. So on the left we have a lentiginous compound nevus showing the junctional nest at the tips of the rete ridges, and on the right there's very good architectural disorder. You can see that in addition to a nest at the tip of the rete ridge, they're also present along the sides, and these are arrowed to highlight that. Now, it took a long time for people to go along with the grading system of mild, moderate, and severe. I remember when I was in the UK, people didn't grade dysplastic nevi at all. They were very resistant to that. Although I have a feeling, that this was part of the. It was a continuation of the American War of Independence. So if America decided we ought to grade dysplastic nevi, the British decided, oh no, we can't do that. But those days, fortunately, are long since past. And so I think up until 2019, everybody was fairly comfortable with grading dysplastic nevi. Certainly, when I moved to Boston, it was obligatory. If you used the term dysplastic nevus, you had to grade it. And if you didn't, the dermatologist would phone you up and say, well, why didn't you grade this nevus? So you'd have to issue an addendum giving the grade. And essentially, mild, moderate, and severe was basically based on nuclear size. If the nuclear size was similar to that of a keratinocyte in the mid-prickle cell layer, it was mild. If it was between 1 and 2 times the size, it was moderate. And if it was 2 times or greater, it was severe atypia. And that table shows you the additional features of hyperchromasia, or vesicular nuclei being found in more severe lesions where there was also prominent and enlarged nuclei. And then, for reasons that I don't really understand, the WHO, in their wisdom, decided to scrap Marty Mims' grading system and introduce a new one, which has the merit, I think, of, well, it makes one aware that high-grade dysplasia is something that you need to pay great attention to, because there may be an adjacent or an associated focus of in situ melanoma, whereas this is very unlikely in low-grade dysplasia. But the trouble is, if you have a very typical dysplastic nevus with wonderful architectural disorder and bridging and fibroplasia and so on and so forth, if the nucleus is only one time the size of a basal keratinocyte, but it's the nuclei are hyperchromatic and irregular, I just don't see how you can not call that a dysplastic nevus. So I took the easy way out, and I lump what used to be mild and moderate dysplasia into low grade. So I've essentially I've ignored the concept or the discussion as to why we have low and high grade dysplasia, but I do use those terms because I think they're important. So this is low grade cytological atypia. This case was courtesy of Dr. Eha Hajduk, and you can see that the nuclei are there's a little bit of variation in nuclear size. The nuclei are larger than the basal keratinocyte nucleus, and small nuclei are present, and this example shows extensive bridging. And there's high-grade atypia courtesy of Dr. Luca Conti, and you can see the nuclei are very large and nuclei are prominent. And there's another one that Pembrokeshire Goons shared with me, and you again see very large nuclei, prominent nuclei and bridging. So I think the difference between low grade and high grade should be obvious. Differential diagnosis of a dysplastic nevus. Well, in the context of this talk, the only thing I want to think about is evidence of melanoma. And on the left, we've got a high-grade dysplastic nevus. On the right, you can see there's quite obvious pagetoid spread. And it's the pagetoid spread that enables you to come to a diagnosis of in situ melanoma. So a few examples. This is a lovely dysplastic nevus. In fact, it's one of the most beautiful ones I've ever seen. And I think it's instantly recognizable even at this magnification, because you can see this tremendous lentiginous hyperplasia. It's a compound lesion with a junctional component extending well beyond 3 leafy ridges on either side, and there's obvious lamellar fibroplasia. One can't tell much about the grade of the lesion, but I think you should be able to recognize that instantly as a dysplastic nevus and nothing else. And there's a closer view. You can see that there is architectural disorder and there is bridging. And there's a closer view showing extensive bridging, and another high power view showing the same. And the nuclei are greater than 1 times the size of a basal keratinocyte. So this is a nice low-grade dysplastic nevus. And this is another one that Ihar shared with me. I showed you a high power view from this lesion earlier on. And here we can see extensive bridging and low-grade dysplasia. And here's a high-grade lesion that Penbergel shared. Even at this magnification, I think you can probably recognize it as a high-grade dysplastic nevus, because the nuclei are clearly enlarged even at this magnification. But when we look a bit closer, the high-grade nature of the lesion becomes more obvious, and these are fields taken from that lesion where the nuclear pleomorphism is very marked, and there's obvious bridging. So that's high-grade dysplastic nevus. And this is another one that Antonina shared. It's a junctional lesion, and you can see some bridging on the right-hand side. I marked a small field where the cells are rather spitzoid looking. Now, it doesn't really do anything for me, but some people would look at that and say, well, it's showing spitzoid features, so we'll call it a spark nevus. I think that's just overcomplicating things. We have enough categories of nevi without adding to them. But that's just me. And at high power, you can see the nuclei are in excess of 2 times the size of a basal keratinocyte nucleus, and there are prominent nuclei, and there's bridging. So that's a high-grade dysplastic nevus. Immunohistochemistry and molecular. Well, I don't really think there's any place for immunohistochemistry in making a diagnosis of dysplastic nevus per se. I think immuno does have a role to play if you're worrying about melanoma arising within a dysplastic nevus. And I think SOX10 can be very helpful in identifying pagetoid spread, which might not be so apparent on the H&E. And in a compound lesion, HMB45 can be helpful, because if the dermal component is very strongly positive, then it would suggest that you're looking at a melanoma arising in a dysplastic nevus. a lot of times people are using PRAME, and well, perhaps it is helpful. I'm not entirely convinced that it's of great value, and there are some publications showing that high-grade dysplastic nevus are express PRAME. Although, mind you, I wasn't able to read the articles themselves, and so it may be that these are misdiagnoses, and in fact they weren't high-grade dysplastic nevi at all. They were melanoma that wasn't recognized. So I think the jury's still out on PRAME. And here's one that did have some immunohistochemistry. This is another one from Pembergol, and there's a medium power view showing tremendous architectural disorder. So I don't think there's any doubt about the diagnosis of dysplastic nevus. And there's that view that I showed earlier on. It's such amazing bridging, absolutely amazing, beautiful. And I've arrowed some obvious high-grade nuclei with prominent nuclei, and Pembergol did all this and I suppose the mRNA is useful, and the SOX10 is useful because there was no evidence of pagetoid spread, and PRAME was negative. So if you want to do immuno, it's fine, but to be honest with you, I think the diagnosis of dysplastic nevus is made on the H&E and nothing else. As for progression, it used to be taught in my day that low-grade progressed to mild dysplasia progressed to moderate dysplasia, progressed to severe, which progressed to in situ melanoma, and there's absolutely no evidence to support that concept. Having said that, I think it is important to recognize that melanoma may arise within a dysplastic nevus, particularly high grade, and you need to look carefully at high grade lesions. Overall risk of developing melanoma, where if you only have one or two dysplastic nevi, there's no increased risk whatsoever. It's been assessed that if you have 10 or more, then you're 12 times more likely to develop melanoma. I'm not sure whether I believe that or not, but it's in the literature, so you may as well know it. I think patients with dysplastic nevus syndrome are in a different position altogether, and they do have a significant risk of developing melanoma. And if a patient has 2 or more siblings with melanoma, then the risk is 100%. And this is a nice example of melanoma arising in the dysplastic nevus that Antonina shared. The top 2 cuts show dysplastic nevus, the bottom shows melanoma, and there's the dysplastic nevus component there, which is junctional and shows nice bridging. And this is the middle of the lesion, and this is the melanomatous component, where you can see there's an obvious involvement of the papillary dermis, and there's some various higher power magnifications, and I think it's the diagnosis of melanoma is very obvious. And this is the one that Ihar shared, a female of 26 who obviously liked the sun a lot, and this is, in this case, there's nice, very obvious dysplastic nevus on the left and on the right, and in the middle there's melanoma, and there's some arrows there showing you melanoma in the dermis, and there's a high power view there showing a very atypical dermal component with no evidence of maturation, so that's melanoma. And then lastly, re-excisions. And again, when I was in the UK, nobody re-excised any dysplastic nevi, whereas when I was in America, oh, they seemed to be always getting re-excised, although this was partly because so many dysplastic nevi were shaved, biopsied, and involved margins, and so you could report on the dysplastic nevus that you were looking at, but you had no idea what was present in the residual lesion in the patient. So if you do have decent margins and they're uninvolved and clinically it's fully excised, then I don't think you need to re-excise it. If it is involved in the margins, some authors suggest that it doesn't need to be re-excised if the clinician is happy that there's no evidence of residual nevus. I'm not very comfortable with that, and I would still recommend a re-excision. High-grade dysplastic nevi always merits a re-excision if margins are involved. Some authors say if margins are uninvolved, you don't need to re-excise it. I'm very uncomfortable with that because sectioning, when you look at the sections from a dysplastic nevus, you can only comment on the sections you look at, and obviously unless you serial section the whole thing, you really don't know whether the margins are uninvolved or not. So I would still get it re-excised and recommend a 2 millimeter margin. So finally, issues with dysplastic nevi. Well, the first thing I would say, and this is the experience I've had from looking at people's comments on McKee down, the first thing is you need to keep to the rules before you make a diagnosis of dysplastic nevus. It must have architectural disorder, and if it doesn't, then it's not a dysplastic nevus. It's some sort of other atypical nevus, but it's not dysplastic. So I would ask you to pay attention to the architecture of atypical nevi. And then there's the problem of distinguishing between high-grade dysplastic nevus and in situ melanoma, and I think that can be very difficult. And nowadays with immunohistochemistry, particularly with SOX10, if you're worrying about whether there is or isn't a melanoma, as I mentioned earlier, that's one circumstance where I think immuno can be helpful. There is the risk of litigation from over or underdiagnosis in America, and perhaps it's becoming more of a problem elsewhere. Personally, I think that's a good thing because it keeps you on your toes. It makes you look at things carefully, and it stops people having a sort of a slapdash approach to the lesion. So I think it's all to the good. It's interesting that a lot of the cases that I see in consultation from outside America are fully excised lesions. So I don't know how much of a problem shave and punch biopsies is for other countries, but certainly when I was in the States, it was a big problem. And then lastly, the change from the 3-tier system of mild, moderate, severe dysplasia to a 2-tier low and high grade system. I think that's one just has to live with it. The WHO have recommended it, and I think it's important that we all follow their recommendations, largely because it's always helpful if we're all talking about the same thing. Then we can make comparisons between a series published by Dr. A and a series published by Dr. B. If we're using the same criteria, then we can make comparisons. So I hope that's been of some use to you, and let's hope that we can see an improvement in the diagnoses of atypical nevi on the McKee arm. So thank you very much.